So no matter what subtype of diabetes you have, diabetes mellitus you have, the common problem is chronic hyperglycemia. Okay? The different subtypes are really different causes of this chronic hyperglycemia. And so along with that chronic hyperglycemia are disturbances in carbohydrate and fat metabolism. Okay? And the disturbances in carbohydrate and fat metabolism, the details really depend on the cause of diabetes mellitus. And so if you recall, the term diabetes is shared with diabetes insipidus that simply described polyuria, polydipsia, right, just producing far too much urine and dehydration and being very thirsty. And so for diabetes mellitus, the cause of the polyuria, polydipsia, dehydration is the hyperglycemia. Okay, and we'll talk about that as we go through. So we went through these things. Okay, so you went through this on your own. Let me just see if there's anything I want to. So you read about these primary mechanisms that are in place to control blood glucose, right? And they're antagonistic processes. So antagonistic processes include glycogen synthesis versus glycogenolysis, right? Producing increasing muscle mass as opposed to gluconeogenesis, where you're breaking down muscle mass, right? Lipogenesis, where you're producing stored fat, versus lipolysis, where you're breaking down stored fat. Okay, so these are all these processes that are used to make sure that blood glucose is always within your normal range, and whether you're in one phase versus the other is really dependent on whether you're in a post-absorptive state or an absorptive state. Okay. Okay, and you learned about that during an absorptive state, when you consume food, blood glucose is rising because glucose is being absorbed, and then as soon as that happens, your body is basically sequestering blood glucose into different tissues, okay, to prevent too far a rise. So you get through insulin, you get blood glucose entering skeletal muscle, blood glucose entering triglycerides, adipose tissue, and entering the liver. The glucose that enters skeletal muscle is going to be stored as glycogen. The glucose that enters adipose tissue is going to be stored as fat. And the glucose entering the liver is going to be stored as glycogen as well. And the amino acids that we consume during a meal are also entering skeletal muscle in order to produce more muscle. Okay. In a post-absorptive state, when you're no longer consuming food, now the goal is actually to maintain blood glucose and prevent a fall. Okay. Now that means, number one, that we have to shut off this uptake of glucose from any tissue that really doesn't absolutely need it. Okay. So that means that insulin levels fall, so skeletal muscle stops taking up glucose, adipose tissue stops taking up glucose, and so does the liver. In addition to that, the amino acids that are in circulation, there's no I didn't draw like a red lines, but the amino acids are also not being taken up by skeletal muscle anymore. Okay? They are actually going to be taken up by the liver, if necessary, to feed gluconeogenesis. And instead of adipose tissue producing new stored fat, it's going to break down the stored fat, okay, so that we can free these free fatty acids for skeletal muscle and other tissue that to be used as an alternate energy source. The glycogen that's in the liver is going to actually get broken down and freed into the bloodstream. Okay? And what's not shown on this slide, okay, in terms of inputs and outputs, can anybody think of an important output for blood glucose that's not being shown on this slide? What's that? CNS, right? The entire time you are fasting, your central nervous system is constantly taking up blood glucose. Okay? So just preventing glucose from being taken up by fat tissue, the liver, and skeletal muscle is not enough to maintain blood glucose, because the central nervous system continues to take. Okay? So what's important for maintaining blood glucose is to constantly have the liver produce new glucose, okay, either from stored glucose or from new synthesis. Okay, so that's an important piece, is that glucose is constantly being siphoned off by the central nervous system during the post-absorptive state. Okay. All right. So you learned about insulin and glucagon being the primary hormones of glucose regulation. Okay? And insulin is released during meals when blood glucose rises, and glucagon is released in the post-absorptive state when when insulin drops and blood glucose declines. So in terms of the release of insulin by the body, blood glucose levels are not the only thing that controls the release of insulin. Okay? In fact, when you consume a meal, okay, you actually get an initial phase of insulin release. It's this short-lived spike of insulin release that happens before you have any change at all in blood glucose. Okay? Before you have any change at all in blood glucose. It's an anticipatory release of insulin, and it happens along with all of the other anticipatory components of eating. If you remember the cephalic phase of digestion, right? What happens in the what's triggering the cephalic phase of digestion? Smelling food, right? Tasting food, right? Just being hungry, looking at food, okay? And then chewing food, swallowing food. Everything in anticipation of food actually entering the GI tract. And we call it cephalic because it's controlled by the brain, and it happens before anything enters the GI tract. Okay? So this initial release of insulin is part of that cephalic phase of digestion. Okay. So let's think about that. What does that mean? Let's say you're hungry. You're sitting in lecture and the person's droning on, and it's lunchtime and you're hungry, right? And you pop in a piece of chewing gum. Okay? So now it's sugar-free chewing gum, right? It's 0 calorie because you're watching your weight and all that stuff. And you're chewing, okay? What's going on in terms of insulin? You already are starting to get a rise in insulin. And what's that going to do in terms of your situation for being hungry? it's not going to help you, right? Because that rise in insulin is anticipation. It's about tasting the gum, chewing the gum, swallowing the juices from the gum, right? That all of that is anticipation of you actually getting food, right? But instead, what you're doing is you're getting a spike of insulin, but you're not giving your body any food. So that spike of insulin is actually going to make you more hungry because it's going to drop your blood glucose even more. Okay, so you're going to go from hopefully a healthy fasting glucose to potentially slightly under that. So this anticipatory rise in insulin is short-lived, but then you get another phase of insulin release that is caused by a rise in blood glucose. Okay. So without that second phase, insulin levels would go up and then back down immediately. It would just be a single spike. Okay? But the second phase, which you don't see the first part of it because it's hidden by the spike, the second slow phase of insulin release is caused by the rise in blood glucose. Okay? And as you can see, we'll talk about this more with type 2 diabetics. They do have insulin, but they have some insulin resistance, and then eventually they have problems with insulin release. They start to, early on, have problems initially with that first phase, okay? But have a somewhat delayed but preserved second phase of insulin release. And then in in type 2 diabetes, both phases of insulin release is affected. So we'll come back to this to talk about that when we talk about type 2. All right. All right. So let's talk about these different types of diabetes mellitus. We classically think of diabetes as being composed of type 1 diabetes and type 2 diabetes. And that really encompasses the vast majority. Those two types encompass the vast majority of diabetes types. And then there are other syndromes, other types of diabetes that tend to act similarly to type 1 and type 2, okay, or type 2. So type 1 diabetes is really in true type 1 diabetes is characterized by an autoimmune destruction of pancreatic cells. Okay? And sometimes that autoimmune destruction involves just the beta cells. Sometimes the autoimmune destruction involves beta and alpha cells. Okay? So there's some variety in the targets, but it's a primary autoimmune destruction of pancreatic cells. And that leads to what we call an absolute insulin deficiency. And what I mean by an absolute deficiency is that the measurable level of insulin is low. Okay? Type 2 diabetes. Type 2 diabetes is characterized by insulin resistance, okay, and what we call a relative insulin deficiency. Now, the deficiency isn't absolute because type 2 diabetics often still have insulin, sometimes very high insulin, at least the measurable amounts. But the deficiency is about the fact that their insulin levels are not high enough to overcome their resistance and maintain normal blood glucose. Okay. So type 2 diabetics have an insulin resistance, meaning those cells with the insulin receptors are not responding adequately to insulin. Okay. And so the person's insulin levels are not high enough to overcome that resistance and maintain normal glucose. Now, these other syndromes, other forms of diabetes, include a fairly broad category of diabetes called maturity onset diabetes of the young, or MODY. And these conditions are caused by genetic defects in beta cell function. Okay? So they can include things like mutations in the genes that produce insulin, that code for insulin. So the insulin that's produced is minimally effective. Okay? Or the responsiveness of the beta cells to changes in blood glucose is impaired. Okay. What did you say? I'm sorry. The second one was that the responsiveness of the beta cells to changes in glucose is impaired. So you don't get a timely release of glucose, of insulin. Okay. But all of the MODY disorders are some kind of genetic defect of beta cell function, their ability to produce functional insulin in a normal way.
So for that one, if they're in a sort of state, it wouldn't be enough to be inadequate during the season.
Right, right. So, for example, a type 1 diabetic, they just don't have any endogenous insulin, right? So you consume food and you don't get an insulin response. And let's say for a MODY patient, you consume food, you get an insulin response, but that insulin only has, let's say, 50% effectiveness, right? So the MODY disorders behave like a mild form of type 1. Okay? They behave similarly to like a mild form of type 1. And when I mean behave clinically. Okay? And then there are some like secondary causes of diabetes, meaning that they're secondary complications of some other primary problem. So for example, problems with pancreatic function in general, like chronic pancreatitis, right, where you just get this really significant inflammation of the pancreas, and pancreatic function goes down. And usually both exocrine and endocrine function of the pancreas is affected. Okay. So the diabetes is really, it's going to act like a type 1, right? And it's going to be a secondary complication of this of this chronic pancreatitis. Right? Obviously, partial or complete pancreectomy, pancreatic cancers, and then cystic fibrosis. Cystic fibrosis is it's a hereditary disorder that affects exocrine glands throughout the body. But with cystic fibrosis, the primary organ that we think about being affected is the lungs, because the patients with cystic fibrosis produce this incredibly thick respiratory mucus that causes multiple respiratory infections, and usually that's the cause of death, is a respiratory disorder, some sort of really bad respiratory disorder. But the pancreas is also an exocrine gland, and so the patients with cystic fibrosis also tend to have pancreatic failure at some point, okay, which also causes the lack of insulin and glucagon production. Okay. Certain endocrine disorders like acromegaly we talked about. Acromegaly is that excessive growth hormone, okay? And that with excessive growth hormone you get excess of insulin-like growth factor, and it increases the risk of hyperglycemia, which so this one is going to act like a type 2 acromegaly. Cushing's, this excess of cortisol or corticosteroids, which also causes chronic hyperglycemia, also going to act like a type 2. Okay. And the same with hyperthyroidism, that it's going to also trigger a rise in blood glucose. Okay. In certain infections, so this is very interesting, that certain infections, I forget which one this one, I think, is it Fifth's disease? Yeah, this one is hand, foot, and mouth. I forget which one that one is. But these, it's not like these infections cause diabetes per se, but childhood, getting these infections early in childhood is associated with triggering in children with the latent ability, triggering the autoimmune attack that's of the pancreas that's involved in type 1 diabetes. Yeah. No, it's usually after, yeah. Yeah, and sometimes it's not too much long after, maybe a couple of years or, yeah. So and you have to keep in mind, and we'll talk about this when we talk about type 1, these patients already have the autoimmunity, sort of the genetic predisposition, okay? They already have it. But the infection basically activates their immune system and can activate the autoimmunity, okay? So this is really about if you look at type 1 diabetics, the ones that have that classic juvenile onset, there's a high association with these childhood infections. And then some drugs tend to elevate blood glucose, causing chronic hyperglycemia, and again acting like a type 2. Okay? And then certain genetic syndromes like Down syndrome, Turner's, Klinefelter syndrome, they have a high association with diabetes. There's something about the genetic abnormality that the same chromosomes that are affected with in these disorders also tend to carry genes that regulate blood glucose and insulin. Okay. And then gestational diabetes is a temporary diabetic state that complicates a small percentage of pregnancies. We'll talk more about gestational diabetes, but with gestational diabetes, usually there is a vulnerability, right? There is some sort of hereditary genetic vulnerability or environmental lifestyle vulnerability, and the demands of pregnancy, especially the effects of many of the pregnancy hormones, okay, create a temporary diabetic state. And it's temporary because with delivery of the baby and the placenta, those placental hormones go away, and the mother's no longer diabetic. Okay? But we'll talk more about this because gestational diabetes is a really good, the pathogenesis of this disease is really a good exercise in better understanding type 2 diabetes. All right. So with all of that said, really the most common types of diabetes is type 1 and type 2. Now, type 1 is, there are other terms to describe type 1 and type 2 that you have to be used with great care because we've found that there are a lot of exceptions to these statements. So type 1 diabetes is sometimes referred to as juvenile onset diabetes, right? Because the classic time course is that the development starts in childhood, and then the disease becomes clinically manifest either in prepubescence or maybe during puberty or just before that time. Okay. However, there are adult onset versions of type 1 diabetes. Okay. There's, does anybody know the woman who wrote the vampire series, Anne Rice, right. So Anne Rice wrote the Interview with a Vampire and the whole vampire trilogies, and she's a fantasy fiction writer. And she, at the age of, I believe, her mid-40s, developed adult onset type 1 diabetes. I'll post this article because it's a great article, but she basically wrote a long, wrote about it in the New York Times a few years ago, because what happened, the way things developed, she mysteriously started to lose weight, she started to have really bizarre symptoms, and then by the time it was caught, her blood glucose was somewhere between 800 to 1,000, and she had gone into a coma. Right? So it's a really, it's not as common as the juvenile onset, but it does occur, the adult onset type 1. Okay. Type 1, and then the other thing is that, type 2 diabetes, we always tended to think of adult onset, but more and more children are developing type 2 diabetes. Okay. Children as young as 7, 8, 9, 10 developing type 2 diabetes. Okay? So juvenile onset, adult onset, really no longer a valuable terms. The other set of terms that are also not as valuable as we used to think is insulin dependent versus non-insulin dependent. So type 1 diabetics from the get-go, absolute insulin dependency, because they have an absolute insulin deficiency. Type 2 diabetics can be treated very early with insulin. Okay? However, at some point, almost all type 2 diabetics in very late stages of the disease will be dependent on insulin. Okay? Part of the sort of lifespan of type 2 diabetes is that eventually their pancreas does get destroyed, and they become insulin dependent, and an absolute insulin deficiency develops. Okay, so you have to be very careful with the use of those terms, and really more and more using insulin early in type 2 diabetes is becoming more and more common and seen to be more valuable. Yeah.
When a type 2 diabetic progresses to that,
yeah.
type 1, how do you then differentiate between, I guess it's like blurred?
It's really just described as late stage type 2, yeah. Mostly because what destroyed their pancreas was not an autoimmune destruction. But they're going to be treated just like a type 1 diabetic, yeah. Okay. And then we have some pre-diabetic conditions. Now, the pre-diabetic conditions describe a time period where the presence of diabetes is not obvious, it's not clinically obvious, but it can be detected with abnormal results from certain diagnostic tests, including a fasting blood glucose. Okay. Now, pre-diabetic conditions more common in the type 2 diabetics, because the type 2 diabetics tend to have a longer preclinical stage. Type 1 diabetics, their preclinical stage is really, their body starts to destroy the beta cells, and once they get to about 75% destruction, all of a sudden the clinical onset is very abrupt. Okay? So they have really a shorter preclinical stage than type 2. So the pre-diabetic stages are, there's two terms to describe them, and it's based on the two main tests for diagnosis of diabetes mellitus. There's an impaired glucose tolerance, which is based on the oral glucose tolerance test, or impaired fasting glucose, which is based on just a simple fasting glucose. So the oral glucose tolerance test involves consuming a drink that has a high concentration of glucose. It's any woman who's ever been pregnant has been through this test, because I think at about 20 weeks or so, every woman has to take this. And the drink is just foul. It's like the worst tasting Gatorade you'll ever consume. But there's about 75 grams of glucose if you're not pregnant, and about 100 grams if you're pregnant. So you drink this drink, you come fasting. So you come to the test fasting. There's a fasting glucose that's taken, okay? And then you drink the drink, and then after you drink that drink, you have blood draws at 30 minutes, an hour, and 2 hours. Now, for most pregnant women, they usually just do one blood draw, and if it's normal, it's fine. But if it's abnormal at all, they repeat the test with the 3 time points. Okay? So what you expect is that the person's blood glucose, so a normal individual, they'll consume the glucose. So they'll come fasting, they'll have a normal fasting blood glucose of anywhere between 80 to 100, depending on the assay. Then they'll consume the drink, and their blood glucose rises. Right? So there'll be a peak. Now, after that peak, you'll have a decline back to normal. Okay? So what you're expecting to see is at 30 minutes, glucose levels are high or higher, and then at an hour and 2 hours, your glucose levels are dropping. Okay? And usually by 1 hour, your glucose level should be back to normal. And I think that I'm wrong. I think that when you're pregnant, you could do two time points, not you do a peak and a norm, right? So you're looking for the peak and you're looking for the coming back to normal. And if anything with the peak and the second time point is off, then you do 3. So with a patient with diabetes, okay, the peak will be higher, and the time it takes to come back to normal will be much slower. Okay, if they come back to normal at all. So it's a very useful test. However, if there's a suspicion, a high suspicion that the patient does have diabetes, the oral glucose tolerance test is not recommended. Right? Giving a patient a jolt of glucose if you really suspect that they're diabetic is not recommended. Okay. So the oral glucose tolerance test is very, very valuable for figuring out if people have a pre-diabetes, so very early diabetes, either pre-diabetes or very early actual diabetes. Okay. And the other thing about the oral glucose tolerance test that's very helpful is if we go back to this slide, someone can actually be pre-diabetic and have a normal fasting glucose. Okay? So they can manage to have a normal fasting glucose, but then when you challenge their system, because really that's what the oral glucose tolerance test is, it's a challenge test. When you challenge their system, what you find is that they may have an altered first stage of insulin release. Fasting blood glucose doesn't tell you the status of the first stage. Okay? And usually the first phase is the one to be affected very, very early on. So the oral glucose tolerance test is going to be able to tell you if they have something abnormal with that first spike of insulin. Okay. And then the other thing is, why is it an oral glucose tolerance test? Why isn't it just they give you a bolus, IV bolus of? So why do you have to orally consume the glucose? Why isn't it just a? Exactly, right? If you did just an IV glucose tolerance test, a normal patient will not have this first spike, right? They'll just have that second phase. So it has to be consumed orally in order to stimulate that cephalic phase and in order to get that first phase of insulin release. Okay? Now, for patients, oh, here we go, I forgot that I put one in here. So for a normal individual, so that's the blue line, so fasting, a half hour, 1 hour, 2 hour, and then 3 hours. So the patient comes in, you get a fasting glucose, they're about 80, they're normal, so this is the purple line. They consume the drink, and then at a half an hour, you see the spike, you see the peak, and the peak is about 140 or so. That's a normal call it a post-prandial, or whatever, I forget what they call it. And then at 1 hour, it's lower, okay? At 2 hours, it's much, much lower, and at 3 hours, you're almost back to fasting. Okay? Now, in someone who's pre-diabetic, the green line, so notice that they come in, their fasting glucose actually within normal limits. Right? However, they take the drink, and their half hour is higher. The 1 hour, it continues to rise, right? So the peak actually comes at 1 hour. And then the fall is much more slow, and even at 3 hours out, their glucose level is higher than normal. Okay? And for an actual diabetic, someone who comes in and their fasting glucose is within the range of diabetes. Okay? Their actual, an actual diabetic, their blood glucose will get very, very high. They'll start off high, they'll get very, very high, and they'll stay that way past 3 hours. Okay? No, you don't. This is just to illustrate what it would look like. Yeah. So, the normal fasting glucose should be 100 or below milligrams per deciliter. And again, this is really depending on the lab that's doing it and what assays they're using. They'll usually give you a reference range. It also depends on whether you're using mixed blood, so capillary blood, or if you're using venous blood. Okay? If you're doing a finger stick, that's capillary blood, which is mixed, right? If you're doing a blood draw, that's venous blood. So I believe that the capillary blood, the finger stick, is actually an underestimation of blood glucose. You get a slightly lower number with capillary blood. Okay, so it really depends. So usually on the lab sheet there's a reference range. The pre-diabetic range for a fasting glucose is usually between 100 to 126. Okay. And true diabetes starts at above 126. There's another test that's also, it used to be primarily used for managing diabetes, and now it's actually starting to become a useful screening tool, for a diagnostic tool. And that's what's called the HbA1c, or the glycosylated hemoglobin. So what this is doing is looking at, within red blood cells, within the hemoglobin, how much hemoglobin has glucose attached to it, literally glycosylated hemoglobin. Okay? So glucose has somewhat of an affinity for hemoglobin. It doesn't interfere with oxygen binding or anything like that, but the higher your blood glucose level, the more glucose will attach to hemoglobin. So you'll have more hemoglobin with glucose attached to it. So that's what HbA1c is. And it's given in a percentage, so percentage of hemoglobin that's glycosylated. Now the useful thing that HbA1c does that none of these other ones do, these are all just a snapshot in time, you know? When you do a blood value for glucose, you're just getting a snapshot of that one moment in time. With HbA1c, you're really getting an average, okay, of what the blood glucose was over an extended period of time. Now, generally, it's believed that HbA1c gives you an average of basically the last 3 months of blood glucose. And the idea is that red blood cells tend to last about 3 months in the body. And so that's the time frame you're looking at. However, the influence of that 3 months over the HbA1c value, there's a much greater influence of the last 2 weeks. Okay? So if you had good control over 3 months, but really bad control over the last 2 weeks, your A1c is going to be higher than it would be if you had sort of the same control the whole time. Okay, and the vice versa. If the first 2 weeks of your first few weeks was bad, but your last 2 weeks was really good, then you're going to get a lower A1c. Hopefully that makes sense. So normal A1c is about less than 5.7. Pre-diabetic range is about 5.7 to 6.4, and above 6.5 is thought to be diabetic. Okay. And oftentimes the targets, when people are being managed, the targets for management are often expressed in A1c levels because it's a better judge of the average. Okay. So type 1 diabetes, talk a little bit more about type 1. It's immune-mediated absolute insulin deficiency, and really only 10% of all diabetics fall into a type 1. Okay? The vast majority of diabetic patients have type 2 diabetes. Now, there are people with type 1 diabetes that sometimes referred to as idiopathic. Now, even the idiopathic type 1 diabetics, they're really still thought to be, they're still thought to be an underlying autoimmunity, but it's, there's no clear markers for autoimmunity. Okay. But the mechanism is still highly suspected to be autoimmune in nature. Okay. Now, for these diabetics with the absolute insulin deficiency, they often will have exceedingly high glucagon levels, especially early in the disease. Okay. Especially early in the disease. And again, that's because in the absence of the insulin, the alpha cells have this sort of chronic stimulation to release glucagon. Now, as the disease progresses, those alpha cells sort of burn out. Right? This constant stimulation from having the deficiency of insulin, those alpha cells actually burn out, and eventually they actually stop producing glucagon altogether. Okay. But there's this period of time with absolute insulin deficiency where if the alpha cells are still there, they're producing high levels of glucagon. Okay? All right. So, common pattern for type 1 diabetics is the autoimmune destruction starts in childhood, and it becomes clinically manifest, right? You end up destroying enough of the beta cells for the diabetes to become manifest around puberty, sometime around puberty. And there's thought to be, there's something about the rise in hormones during puberty that seems to really precipitate the onset. Okay. Now, with that said, there are children as young as 3 and 4 that have fully manifested type 1 diabetes. Okay. What this is just describing is the classic pattern of onset. Now, while the autoimmune attack takes some time, once you get to about, I said 75%, I was wrong, about 90% or more of your beta cells destroyed, the clinical onset is extremely abrupt. Okay. Once you have critically low insulin levels, it does not take very long for your blood glucose to get out of control very quickly. Now, the mechanisms of beta cell destruction with type 1 diabetes can include, and you can include one or more of these mechanisms: T-cell mediated attack of beta cells, cytokine-induced damage of beta cells during an inflammatory response, autoantibodies against the alpha and beta cells. Okay. And actually, in about 70 or 80% of patients, they will test positive for autoantibodies. Okay. So oftentimes there's a variety. There's multiple mechanisms of immune attack, and these are some of them. And then for individuals with genetic susceptibility, there have been a set of genes that have been identified that are targets for alteration developing type 1 diabetes. And those genes either reside within the area of the genome that codes for those MHCs, okay, which is what we classically think of with autoimmune disorders, right? That it's a problem with one of these self-antigen, one of the genes that code for self-antigens. But then also there's some mutations that have been identified outside of that MHC part of the genome. Okay. And then environmental factors that can precipitate the onset include certain infections like mumps, rubella, and the ones that I mentioned earlier, the hand, foot, and mouth, and cytomegalovirus. Okay. And as I said, these are really triggers. They are triggers that activate that autoimmunity and start the progression. With type 2 diabetics, much more common than type 1. It's associated with hyperglycemia, insulin resistance, and a relative insulin deficiency. Okay. Strongly influenced by both genetic and environmental or lifestyle factors. Okay. So in patients with type 2 diabetes, there seems to be some genetic susceptibility. Okay. And that genetic susceptibility can either be high or low, so there's varying degrees of genetic susceptibility. In some patients, their genetic susceptibility is very high, And even if they are Mother Earth, yoga, healthy to the max, they are going to develop type 2 diabetes. Okay? And then there are people where the susceptibility is not so strong, and it can be much more actively managed and prevented or exacerbated by environmental factors. Okay? And the environmental factors that are thought to be the strongest ones include level of activity or level of sedentariness, if that's a word. Okay. So level of activity and eating habits, including the composition of people's diets. Okay. And one of the strongest risk factors in terms of environmental factors for diabetes is obesity. And we'll talk more about obesity as a major risk factor for type 2 diabetes. So we are constantly learning new and surprising things about type 2 diabetes. It's an area of a lot of research. And so especially in terms of the connection between obesity and some of these environmental factors and type 2 diabetes, we're learning a lot. There's some things that we're clear on, and there's some things that are really still quite enigmatic or not well understood. There doesn't seem to be any, at this point, there doesn't seem to be any evidence to suggest an autoimmune role in type 2 diabetes. Okay? This doesn't seem to be an autoimmune disorder. Now, for type 2 diabetics, there are two main problems that are causing the onset of symptoms. And it tends to happen in sequence. And the first thing is some degree of insulin resistance. So tissue in our body that's supposed to be sensitive to insulin has lost their insulin sensitivity to some degree. Okay? So that's the first thing that happens. Now, the second thing that happens is a result of the resistance. So the body tries to compensate. The pancreas tries to compensate. Okay? It compensates by producing higher amounts of insulin. And it's able to do that actually for quite a long time. So people who have type 2 diabetes, they likely went through a very long phase where they had insulin resistance, but they were compensating well, so their blood glucose was always normal. But eventually, that increased stress and functional demand on the pancreas causes injury, inflammation, cell death, and impaired function. So, number 2 is beta cell dysfunction as a result of this stress on the pancreas. And when that happens, the insulin production is not high enough to maintain blood glucose, and that's why we refer to it as a relative insulin deficiency. Okay. Now, some of the mechanisms for the insulin resistance, there's a variety of mechanisms that have been identified and theorized for the insulin resistance, and it includes things like somehow the tissue is not actually producing or expressing enough insulin receptors. Okay? So if you don't have enough insulin receptors, you're not as sensitive to insulin. Or the insulin receptor is minimally functional, right? It's not functional as much as it should be. Or it could be about the some deficiency in the signaling pathways that insulin works through. So it could be that insulin's binding to the receptor, but then the receptor isn't able to activate the signaling pathway. Okay. And then finally, it could also be a problem with the insertion, the exocytosis of GLUT4 receptors into the membrane. Okay. Any one of these could produce an insulin resistance. So the beta cell dysfunction that happens as a result, it really represents an inability of the cells to adapt to long-term demands of insulin resistance. Okay. So initially, that insulin secretion is higher, and it produces this hyperinsulinemic state, and that allows the person to maintain normal blood glucose. Now, as those beta cells start to decline in function, okay, and the person starts to manifest this diabetes, you start to see things like a loss of the first phase of insulin release, that cephalic phase. Okay, that's usually the first phase of insulin release that's affected. Eventually, all phases of insulin release are affected. So not only do you have less or no of that first spike, then the second spike becomes maybe more sluggish or just lower, right? And then eventually, the beta cells actually start to decrease in mass, right? They're starting to die off. Okay? And eventually, the beta cells are not only all going to die off, but they're going to be replaced with just scar tissue. Okay. And at that point, the person is going to become insulin dependent because they no longer have enough endogenous insulin. And the diabetes now is going to behave, clinically behave as if they're type 1, even though they're late stage type 2. And the onset of this part of diabetes can be greatly delayed with good treatment, right, and good management. Right? It can either be delayed or avoided altogether with relatively good management. But how long it takes someone to get to that point is also in large part just very individualistic. It's really about the person's individual expression of their disease. Okay. So this just represents what I've been talking about, the phases of this type 2 diabetes. So the insulin resistance is the first thing that happens, and it is a result of a combination of genetic predisposition and lifestyle environmental factors like obesity. Okay. As a result of the insulin resistance, in order to maintain normal glycemia and normal glucose levels, the beta cells undergo hyperplasia, and they increase their insulin production. Okay. And at this is a period of hyperinsulinemia, this period of time where their insulin release is actually higher. Now, after this happens for an extended period of time, the beta cells start to express this fatigue, right? They have this chronic inflammation. They're starting to not produce insulin as effectively, and this is where you might start to see an abnormal glucose tolerance test. Right? Fasting glucose might be normal, but maybe you get this impaired cephalic phase, and you get some abnormal results in the oral glucose tolerance test. Eventually, the beta cells are going to continue to dysfunction, and you're going to start to see all phases of insulin release affected, and hyperglycemia in both the fasting state and absorptive state. Okay. Now, obesity is the strongest risk factor for type 2 diabetes. And we're starting to understand more and more about why that is and what the state of obesity really looks like in the body, okay? And how it connects to increased risk of things like cardiovascular disease and diabetes both. And the thought right now is that there is a strong connection between obesity and insulin resistance. Okay? Even in non-diabetic patients, that there seems to be a high association of obesity and insulin resistance. So individuals with obese BMIs tend to express some degree of insulin resistance, regardless of whether they are diabetic or not, or even pre-diabetic. There's something about the state of obesity that causes the body to respond with less sensitivity to insulin. Okay. Now, the reason for that, the reason why obesity seems to produce some degree of insulin resistance is thought to be because of the nature of what being obese really does to those fat cells. So if you think about adipose tissue is actually they're composed of very complex cells, and their function is more than just storing fat. Okay? We're not used to thinking of adipose tissue or fat cells as having any other function besides just storing fat. But they seem to actually have a role in the overall energy balance in our body, maintaining normal energy balance. And when fat cells are forced to accumulate excess fat, they actually are injured cells. So the fat cells of someone with an obese BMI, those fat cells are actually injured, hypertrophied cells. And when someone's BMI rises and gets into the overweight or obese category, and imagine BMI as being not what it is, which is sort of a flawed measure of normal body weight to your height. If you can just think about BMI as being a better measure than it actually is, when someone gets to the point where they are becoming more obese and there's a demand for storing more fat in their body, adipose tissue prefers to expand cells rather than make new cells. Okay? There's a great resistance to making new cells, because once you've formed those new cells, you don't tend to get rid of them. Those fat cells don't tend to die. So first, adipose cells will hypertrophy, okay? And only really under extreme conditions will they hyperplasia, okay, or undergo hyperplasia. And those hypertrophied cells, as I said, they represent injured cells. And whenever you have cell injury, what's happening? How's that responded to? Inflammation. Okay. So individuals who are obese, the theory is that because their cells have this chronic injury, there's more chronic inflammation in those people. And chronic inflammation causes a whole host of bad things, okay, systemically. So, and there's a thought that chronic inflammation is actually what's underlying that insulin resistance. Okay, the chronic inflammation of obesity is what's thought to really be causing that insulin resistance. So, for example, some hypotheses that connect obesity, inflammation, and insulin resistance. Obese individuals tend to have elevated levels of circulating free fatty acids. Okay. Now, we know that free fatty acids can interfere with insulin, the insulin and insulin receptor relationship. So free fatty acids can antagonize insulin receptors. So that's one mechanism, is that obese people have higher free fatty acids and they're antagonizing insulin receptors. Okay. Another one is that the chronic inflammation, so these hypertrophied fat cells, okay, have this chronic inflammation going on. And one of the lines of evidence for this is if you look at the adipose tissue of obese individuals, instead of it having only 5 to 10% macrophages that you would see in a lean person, obese adipose tissue has up to 50% or more macrophage density. Okay? So you obviously have a lot of inflammation because these macrophages are migrating to the area. Now those macrophages maintain the inflammation, right? And they release a variety of cytokines, including TNF-alpha, that also antagonize insulin receptors, especially in, TNF-alpha is a cytokine that is especially capable of antagonizing insulin receptors. Okay. And then finally, the chronic inflammation also increases that lipolysis and the free fatty acid production, which is, going back to number one, antagonizing insulin receptors. Okay. So you have a lot of this potential interference with insulin receptor function and insulin signaling when you have this inflammation associated with obesity. Yeah. Yeah. So when these adipose cells hypertrophy, they're under increased functional demand. So it's a form of stress and it's a form of injury. So when those cells get injured in this way, they themselves release cytokines that attract macrophages to the area. It's a little like when endothelial cells get damaged in the bloodstream and they release cytokines that attract. Yeah. Okay. So it's the fat cells themselves that are injured and distressed that are triggering this inflammation, and then the macrophages sort of continue it, and it's the cytokines and the release of free fatty acids that are thought to really be mediating the insulin resistance. Okay. So that's one part of it, right? The other part of it is that these hypertrophied, stressed out fat cells are also not functioning normally and helping the body regulate its body mass. Okay? So in fact, once people become obese, the thought is that it's actually easier for them to stay obese than it is for them to lose weight, because the derangement of the endocrine function of adipose tissue in maintaining body mass is helping them maintain this obese state. Okay? So what do I mean by the endocrine function of fat cells? So adipose tissue is capable of releasing a variety of hormones and chemical mediators that we call adipokines. Now, adipokines are, think of them as cytokines. So cytokine is just a chemical that's released by a cell, but with the adipokines, it's just the type of cell is adipose tissue. Okay. Now, adipose tissue can release, it releases hormones and these adipokines that really are very important in regulating both appetite and feeding, and also insulin sensitivity. Okay. So, for example, fat cells release a hormone called leptin. And leptin acts on the brain, on the feeding centers of the brain within the hypothalamus, and it tends to actually suppress appetite. So the idea is, the more fat cells you have in your body, the more leptin that's produced, and the more that's supposed to inhibit further feeding. Okay, so that's the theory. And that's if these fat cells are functioning normally. And they also release a series of adipokines that are of particular interest when it comes to understanding the role of obesity and diabetes. One is called adiponectin and the other is called resistin. Now, adiponectin acts on both fat cells and other insulin-sensitive tissue like the liver and skeletal muscle, and it increases the sensitivity of those cells to insulin. That's the role of adiponectin. And resistin, released by fat tissue, is designed to act on, again, all of these insulin-sensitive tissue types, fat, skeletal muscle, liver, and it reduces the sensitivity. It actually increases, it causes a resistance to insulin. Yeah. These are called adipokines, but they're similar to hormones. Yeah, yeah. All right. Now, the only big difference between cytokines or adipokines and hormones is really the concentrations with which they're released. So hormones are released in larger concentrations to act globally on the body, and cytokines, adipokines, they're released in smaller amounts to act on neighboring tissue, but they're still released into the bloodstream. So if you can think about this, so this is in a healthy person with normal, healthy fat tissue. If you are in, so historically we come from mostly either agricultural or nomadic societies, right, in terms of our evolution. And there were, over the course of the year, there were periods of time where food was abundant, and there were periods of time where food was not so abundant, right? You had to get through the long winter where it wasn't where food was scarce, and then you had spring and summer where food was plentiful. Okay? So the idea is, during times where food is abundant, we want to increase our fat stores, we want to increase our glycogen stores, okay? We want to facilitate the uptake of glucose to our tissues. So fat cells help that by releasing adiponectin. Okay? So it's when energy is abundant and we want to load up, because during the lean season, we want to make this insulin-sensitive tissue less sensitive, so it's not taking up so much glucose. It's using its own stores, it's using fat, saving that glucose for the brain, and getting through that season. Okay? So the fat cells really play an important role in this overall management of our energy balance. Now, when these fat cells become hypertrophied and injured because they're hypertrophied, they don't function normally. So injured, hypertrophied fat cells don't release leptin effectively, so they're not suppressing appetite as they should be. They are impaired in their ability to release adiponectin, but they are less impaired in their ability to release resistin. Okay? So the fat cells themselves are releasing this adipokine that's directly contributing to the resistance. Okay? And that's on top of the cytokines of inflammation causing resistance and the free fatty acids causing resistance. Now, not all fat tissue, so being obese is not the only thing that's actually important to consider when you talk about the behavior of these fat cells and increased risk of diabetes. Not all fat is equal, right? So if you are obese but you carry all your weight in your butt and your thighs, right, your classic pear, you are much less likely to have any of these problems. Okay? In fact, I had a friend that loved to quote a set of studies. She was very much a pear, and she loved to quote a set of studies that showed that women who were shaped like a pear actually lived longer, better than women of normal weight without that kind of, that pear shape. So the fat that we carry in different parts of our body are not equal in their ability to increase or decrease pathology. The most toxic the most toxic fat is central adiposity. It's really fat. If you're an apple like me, unfortunately, it's really the bad kind of fat. Okay. And one of the theories behind that is that, for men, a lot of the fat that's carried in the center is not subcutaneous. It's very, very deep visceral fat, right? So if you know these, I'm married to one of these guys that has the hard belly and the red cheeks, but the belly's not, right? It doesn't shake. It's just like a really hard belly because the fat is not beneath the skin. It's beneath the muscle, right? It's visceral fat. So especially in men, and men tend to get that more than women, but whether it's subcutaneous or deep visceral, the fat that's carried in the center of the body so the main theory is that the free fatty acids that are released or the cytokines that are released have greater access to the liver because of their location and can affect the liver more readily. And since the liver is so important in the regulation of blood glucose, it's more affected and increases risk more. So having a high waist to hip ratio is maybe even more than absolute body weight or BMI is a great predictor of complications like diabetes. Okay. And then saying one more thing about this is I didn't see any follow-ups to this, but there was an article posted in the New York Times last semester, actually, that talked about a proportion, I think it was about 30% of individuals who were obese, when they looked at their adipose tissue, they actually seemed to be completely metabolically healthy. So instead of looking like everything that I'm talking about, right, where you've got high macrophages, lots of inflammation, their adipose tissue looked completely normal. So it's unclear whether it's that just some people, that this slice, this 30% represented people who was metabolically healthy for them to be heavy, or if that group represented an early stage of obesity, that the metabolic complications happen later. Okay? But it's not cut and dry, right? So obesity research is just as rapidly expanding a topic as diabetes research, but there does seem to be a group of people that the fat is not as toxic to their body as others. I'll try to find that article and post it. So Anne Rice and that one, I'll post those. So let's take a 2-minute break, 2 to 5 minute break, and come back and talk more about this. So gestational diabetes. Gestational diabetes, as I was mentioning earlier, it's a temporary diabetic state that can occur in pregnancy. Now, it's really defined as any degree of glucose intolerance that where the first onset is recognized during pregnancy. And it complicates approximately about 2.6% of all pregnancies, and that statistic is several years old, so I'm not sure what the current numbers are. I'm sure it's probably gone up, unfortunately. But what happens during gestational diabetes is that the demands of pregnancy really challenge greatly the system of glucose homeostasis in the body. And for a percentage of moms, that challenge uncovers an underlying vulnerability, okay, and manifests in this diabetic state. So to understand what the challenge of pregnancy involves, we have to just talk for a moment about what happens during normal pregnancy. So if we look at this very rough graph, I've got gestational time on the x-axis, meaning from the beginning of your pregnancy, the 40 weeks, 0 to 40 weeks. And we've got two lines here. The red line represents tissue sensitivity to insulin. How sensitive are your tissues to insulin, skeletal muscle, liver, adipose tissue. And the blue line represents the maternal plasma levels of insulin. Okay. Now what you see is that there's clearly two very different phases during pregnancy. Okay. And then there's this real shifting point where things reverse. So these two different phases, we can call them early pregnancy and late pregnancy. In early pregnancy, the mom is essentially doing several things. While her baby is developing, mom is actually putting on, increasing her fat stores. Okay? So the priority of mom's body, early pregnancy, is to increase her fat stores. And this is achieved by increasing tissue sensitivity to insulin, which allows for greater uptake of glucose. Okay? So that those fat cells take in glucose and they convert it to fat, and mom's adding to her fat stores. Now the late part of pregnancy, in late pregnancy, the tide turns. Mom now starts to break down those fat stores and use them as her primary source of energy. And the glucose that she is not using, okay, in late pregnancy is being saved for two things: her central nervous system and baby. Okay? So in early pregnancy, mom's blood glucose is going to do three things. It's going to baby to fuel its growth. It's going to fuel mom's brain and other tissues. And it's being used to increase fat stores in mom. That's early pregnancy. And in late pregnancy, the priority then shifts to preserve blood glucose for mom's brain and for baby. Because during late pregnancy, you've got a pretty large person living in you, okay? You've got a significant organism living in you that that now has a fairly large central nervous system. It now has a brain that really needs blood glucose. But also, during the last few weeks of pregnancy, the baby really needs to increase its glycogen stores in its liver, okay? And it's got to put on some fat, right? Because once it's born, to borrow a phrase from a friend of mine who's a lactation consultant, once it's born, the baby no longer has a womb service, right? I know, it's really corny. But it now has to provide its own glucose. It now has to provide its own glucose regulation. It no longer can rely on mom. So it needs to pack its liver with glycogen. It needs to put on those fat stores. So it's in the best position for extrauterine life. Okay? So what that means is mom becomes insulin resistant during the late phase of pregnancy. Mom is going to become insulin resistant. So you see this red line, insulin sensitivity, goes down, and it goes down below her pre-pregnancy levels. So she becomes insulin resistant, and the resistance is actually a result of a particular hormone called human placental lactogen. It directly antagonizes insulin receptors and causes mom to be insulin resistant. Right? And that just sort of frees up enough glucose for the baby to siphon off. But if you notice, mom's insulin level goes up, and it's in parallel with her insulin resistance. That rise in plasma insulin is designed to keep mom normoglycemic. Okay? In the face of this insulin resistance, this is just designed to keep her normoglycemic. So she's not hyperglycemic. So with women with gestational diabetes, it's this ability to elevate their plasma insulin that's impaired. Okay? So for women who develop gestational diabetes, their pancreas cannot meet this challenge. They can't produce high enough insulin levels in order to overcome that normal insulin resistance of the second half of pregnancy. Okay. So what this is thought to be correlated to is potentially some underlying pancreatic impairment. Right? So if a woman comes into pregnancy with some very, very early preclinical type 2 diabetes, right? We're talking about just some mild insulin resistance, and their pancreas is already working a little bit hard to overcome that. And now you put on top of that the insulin resistance of pregnancy, right? Now mom is really trying, but her pancreas just can't meet the challenge. Okay? So women who develop gestational diabetes very often develop type 2 diabetes later in life. And that development of type 2 diabetes is thought to be both because she already had likely some insulin resistance before pregnancy, and also the demands of pregnancy sort of accelerated the progression towards diabetes because the pancreas is working so hard during pregnancy. Okay? And so if so the idea that the prevailing thought is that if, let's say you're a person who, based on your genetics and your lifestyle, let's say you have your babies between age 25 and 35, but if you'd never had babies, you would develop type 2 diabetes at 45, okay? So the idea is that with every pregnancy, you bring that onset, make that onset sooner and sooner, right? So with every pregnancy, you, I don't know how to describe it. Instead of it being 45, it's going to happen at 40 or 35, okay? Or sometimes women, they go from gestational diabetes to sort of a mild diabetes because they've already, it's been accelerated so much, okay? That makes sense? But with the delivery of the baby and the removal of the placenta and HPL gets removed from your body fairly quickly after the placenta is gone. The insulin resistance goes away, right? And the diabetes should go away. Okay, so that's the idea. Other questions about this, about gestational diabetes? Yeah. No, they will treat it, and I believe so. I think it's primarily through insulin, because I think that many of the anti-diabetic drugs are pretty teratogenic, right? That are not very good for baby. But no, they will treat it because the risk of no treating is higher than the risk of treatment with hyperglycemia. And plus, there's a lot of like management of diet and trying to, yeah.
And what about the babies? Are they chronically themselves with some sort of diabetic?
I don't believe that just being a fetus within a diabetic mother increases your risk of type 2 diabetes. Not that I've ever come across, but certainly, so women any woman can get gestational diabetes, but women who are heavier going into their pregnancy, so women who are obese going into their pregnancy are they have a higher risk. And so just being in that, under those conditions, it increases the fetal risk of a variety of things. So, but no, I don't believe, I've never come across anything about the treatment increasing the risk of the baby becoming diabetic. Yeah. But when a woman is diabetic and the baby experiences high levels of insulin all the time, we talked about the macrosomia, right? The insulin being a growth factor, but also when the baby is delivered, now the baby actually has fairly high insulin and no longer has access to mom's glucose. Yeah, so neonatal hypoglycemia they have much higher risk for that once they're delivered. So there's a lot of complications that are associated with having diabetes during pregnancy, whether it's gestational or pre-existing. It also increases the risk of congenital heart defects, and I mean, hyperglycemia during pregnancy is really there's a laundry list of risks complications that it increases the risk for. Okay. So whether you have type 1 diabetes, type 2 diabetes, there are classic manifestations that are common to all forms of diabetes mellitus because they are manifestations of or consequences of hyperglycemia. So hyperglycemia, glucoseuria, polyuria, polydipsia. Okay? And in fact, it's actually in order of what causes what. Okay? So the hyperglycemia causes the glucoseuria. So when plasma levels of glucose get above the renal threshold, right, then that person is going to urinate out some amount of glucose. The glucose in that urine causes osmotic diuresis, so you get the polyuria. And then the dehydration that results from the water loss causes polydipsia, the extreme thirst. Okay. The classic manifestations of uncontrolled diabetes, of having this hyperglycemia. We also see acute complications of diabetes mellitus that really tends to depend on the form of diabetes the person has. Okay. So acute complications includes hypoglycemia. Now, hypoglycemia is a complication of treatment of diabetes, whether it's treatment using insulin or the oral anti-diabetic drugs. Hypoglycemia is always a potential complication. Hyperglycemic hyperosmolar coma. So if someone's plasma glucose levels get much too high, to the point where their plasma osmolarity gets very, very high, it can cause disturbed mental function, leading to potentially coma. Diabetic ketoacidosis is a problem of individuals with absolute insulin deficiencies. Okay. So that means either type 1 diabetes or very late stage type 2, where people become have an absolute deficiency. And then a similar to diabetic ketoacidosis, minus the acidosis, right? Minus the ketoacidosis, is something called hyperosmolar hyperglycemic non-ketotic syndrome, or HHNK. Okay. Now, what this is basically hyperglycemia, glucoseuria, polyuria, polydipsia, okay, minus the acidosis. And this is something that happens, that describes that syndrome in people who don't have an absolute insulin deficiency. Okay. So let's talk about each of these. So before we jump into hypoglycemia, something to keep in mind about the nature of the hyperglycemia that's characteristic of diabetes mellitus. And this is especially true of type 2 diabetes, but also includes type 1 diabetes. So we know that there's a problem with insulin. Okay? We know that this person either can't produce insulin or they're insulin resistant. Okay? And as a result, when they consume food, especially carbohydrates, it elevates their plasma glucose, and the insulin-sensitive tissue can't take up that glucose, so it stays in the bloodstream. Okay? So that's the obvious part of the hyperglycemia. The less obvious part is that one of those organs, that's among the insulin-sensitive tissue types, is the liver. And if the liver can't take up glucose, it doesn't know that you're in an absorptive state. Okay? So the liver, whose primary job is to regulate blood glucose, you consume food, your blood glucose goes up, but the liver can't access it, so it actually assumes you're still in a post-absorptive state. And what does it do in a post-absorptive state? That's right, it breaks down glycogen stores, it produces new glucose, gluconeogenesis, and it puts glucose into the bloodstream. So liver production of glucose is a major mechanism behind that hyperglycemia of diabetes. It's the fact that the liver, despite the fact that you're hyperglycemic, the liver can't access that glucose. So it assumes that you are in a post-absorptive state. It's really the fact that insulin is what turns that, it's the insulin that triggers the movement from the post-absorptive state into the absorptive state, right? So the liver never gets that cue. It continues to produce glucose. And that's why in type 2 diabetics, some of these oral anti-diabetic drugs actually operate by reducing glucose production of liver production of glucose, and helps manage the hyperglycemia that way. Okay. So that's one thing to keep in mind. So hypoglycemia is a drop in blood glucose below what's normal for your age and your sex. So for an adult, hypoglycemia starts around 60 to 70 milligrams per deciliter. And for children, especially neonates, so babies, their blood glucose levels, their normal levels are much, much lower than adults. Okay? So having a blood glucose level of like 50 or 40 is actually not all that. I don't really know what's normal. But
Well, it's like for a newborn, usually
yeah.
40 is kind of
40 is so below 40 it would be hypo. So much, much lower than the adult norm. Okay? But for an adult, about 60 or 70 is sort of the level where you start to see hypoglycemia. Now, it is the most common acute complication of type 1 diabetes. It's a complication of treatment. It's much more common, or the risk for hypoglycemia is much greater when you're being treated with insulin, but it can also occur with the treatment of using the oral anti-diabetic drugs. Okay. And really what hypoglycemia represents when it happens in someone being treated for diabetes is usually a miscalculation of the timing of the treatment, timing or dose of the treatment compared to the timing of meals. Okay. Now, our body just does it, right? And it does it just beautifully. And a healthy person, the timing is just so elegant and perfect, right? Your body knows when you're about to eat food, gives you a little bit of a spurt of insulin, and then you consume the food, and then you get this nice gradual rise, right? So we're not as smart as our body. We're not as good at that as our body is. So we have to have some sort of guidance on knowing how close to your meals you're going to consume, you're going to take your dose, and then trying to time it to mimic the way the body controls insulin levels with meals. Okay? And some of the complicating factors is you could have that formula just down, right? If you're a type 1 diabetic, you're doing it all the time, you can have that formula down. But if you exercised a little bit more that day, right? When you exercise, your skeletal muscle doesn't need insulin to take up glucose. Okay? So if you exercised, and it's going to take up more glucose. If you've exercised, you don't need as much insulin. Okay? And if you are sick, you need more insulin, right? Because when you're sick or you have any kind of stress going on, infection, your blood glucose tends to be elevated. Okay? So even if you have that routine down pat with timing food and your insulin, things can complicate that relationship. And the better you are, the tighter your glucose regulation is, the greater your risk of hypoglycemia. Okay? It's a double-edged sword. The more vigilant you are at keeping your glucose level close to normal, the greater you run the risk of going under. Yeah.
I looked at neuro, I see may use this intensive insulin protocol because the toxicity is
Yeah.
blood sugar. And maybe we do hourly blood sugar is what we do.
Wow.
So they were either NPO or they had it.
Right.
They were getting constant feeding, but they had such a bizarre, like this spread was too, I don't know, there was one little couple millimeters and then you would have to go up another unit or two maybe, and the people, like they'd be high and then they'd have them there nice and
Yeah.
a few hours cooking along, like 4 hours, and all of a sudden,
Boom. Yeah.
like 40, and then you turn it on, like
Yeah.
the P50, that whole thing.
And you're really titrating. It's really, yeah.
And it was, they stopped doing it. I mean, it has fallen. I mean, some people still do it. It has fallen out of favor because
Yeah.
too many episodes.
Yeah. And that's interesting. So these are patients in the neuro ICU, and they're not diabetic, but they're on NPO or G-tube feeding, right? Which means that first phase of insulin never happens for those patients because they're not consuming food to their mouth. Right? They're either getting the TPN, or they're getting feeding straight into their stomach. Yeah, yeah, exactly. So a lot of things that go into this. So that's why when you look at targets, like whether it's A1C levels or blood glucose levels, when you look at management targets for diabetics, it's always higher than normal, right? Because there's this buffer that's built in to sort of balance the risk of hypoglycemia over the risk of hyperglycemia. So when someone becomes hypoglycemic, right, they don't usually go from normal fasting to, so we're talking about in the context of hypoglycemia outside of diabetes, okay? When someone becomes hypoglycemic, they don't go from 100 to 40, right, in a second. There's usually a gradual decline, right? And very, very early stages of hypoglycemia, when you're starting to really get low, you have this autonomic response. And we actually are all familiar with it because whenever you haven't eaten for a long time, you will feel a little bit of this, okay? And it's just this, the adrenergic response when your body, the sympathetic nervous system kind of turns on and you start to feel sort of shaky, a little bit of tremor. You might have some anxiety, you might have some tachycardia, feel sort of palpitations. This is when we're really talking you're getting hypoglycemic. And you'll feel hungry, you'll start to sweat, right? Now this autonomic response, whenever the sympathetic nervous system turns on, it releases catecholamines, releases epinephrine, norepinephrine, and that will tend to elevate your blood glucose a little bit, right? You also are likely getting the release of glucagon. That's elevating blood glucose a little bit. So the autonomic response is designed to sort of be a bridge between now and when you can get food in you. However, you have to get food in you. And part of that autonomic response, those feelings, is to make you aware of the fact that you are becoming hypoglycemic and to trigger you to go eat something. Okay. I had an old boyfriend that the woman he dated before me was just always chronically dieting, like really severely chronically dieting. And he knew when she started to get really grouchy, he needed to get food in her, right? But it was like it went from like like we're going to break up to what are we going to do tonight? You know, so it's a really clear indicator, whether you realize it or other people realize it. It's a really important signal for you to go and feed yourself. Okay, because if you don't, or if you can't, right? There's just no food around you, or whatever. The next thing that's going to happen is your blood glucose will drop, and the manifestations are going to be neurologic. You're going to feel things like fatigue, weakness, drowsiness, headaches, okay, confusion. So that we're getting at the sort of more severe end of the stage. People can actually seem drunk, right? Behave inappropriately. And when you get to the point where they're getting very hypoglycemic and they're getting that neurological stage. And it can get to the point where they have seizures and they get into a coma. Okay. Now, the purpose of the autonomic response is to be a bridge until you can get food in you, and to also make you aware of the fact that your blood glucose is in danger of dropping, right? Now, just like any other thing, just like any other stimulus that triggers an autonomic response, if you get exposed to that stimulus over and over and over again, the response gets lower and lower and lower. Your body adapts. Okay? So if you're someone who's diabetic and you've had a couple of episodes, several episodes of hypoglycemia, it's very possible that the next time you're hypoglycemic, you won't have any of these autonomic responses. Okay? And the first manifestations you'll experience are neurologic. And that is really called hypoglycemia unawareness. Okay? Where you really, because you've had repeated episodes of hypoglycemia, you no longer have that initial response, that initial autonomic response. Okay? And it can become it can be very, very dangerous and embarrassing. I mean, at the very, trivial end of it, it can be quite embarrassing for someone to not realize it, and the first thing the first clue is that they're behaving really inappropriately in a public situation, right? The other thing about this autonomic response, this very, very important initial autonomic response, is that, it really is part of trying to compensate for that drop in blood glucose. It's a little, like I said, a little bridge it sort of gives you enough blood glucose to get you going, okay? And part of that response is a rise in glucagon, which is going to, again, give you that boost of glucose until you can consume some food. Now, the problem is, if you recall, I told you that that for people who with absolute insulin deficiency, that they have this period of time where their glucagon levels can be very, very high, right? But then at some point, their glucagon system can actually burn out, right? Where their alpha cells now no longer can respond and produce glucagon. Okay? And for those patients, whether they've had repeated experiences with hypoglycemia or not, the hypoglycemia can be very severe very quickly because they no longer have this glucagon response. Okay? So for diabetics, becoming hypoglycemic is not just a complication, it's a complication of treatment, but it also is something that can be very easy to do because their body doesn't necessarily have all of the compensatory responses in place. Okay, so it can become very, very dangerous very quickly for them. Okay. So that, before I get onto this, so that initial phase where they're aware, if they preserved this awareness of the hypoglycemia, you know, getting something with sugar in them is really important, right? Drink some orange juice, just eat a cookie, just anything with glucose that can, something with a very high glycemic index, meaning that the glucose is going to be absorbed and enter their body very, very quickly. Okay? Sometimes people have glucagon shots on them that they can take, right? So they can give themselves a glucagon shot. You know those, do you remember those, I don't even know if they're still widely used, but like for runners or for athletes, those gels, those like glucose gels, so those gels also, there's actually a certain amount of absorption of glucose that can happen in the mouth. Okay, so just even getting that into somebody in their mouth can help, right? Even if they're not in a position, neurologically speaking, to be aware and swallow. Right? But so that's usually just getting something, getting that sugar in them, and also potentially giving them glucagon is usually something that's an important part of treating hypoglycemia. Another acute complication is diabetic ketoacidosis. Now this happens in people with absolute insulin deficiencies. Okay? It will not happen in someone with a relative insulin deficiency. Now what happens with diabetic ketoacidosis is they have all the same classic manifestations. So they're acutely hyperglycemic, they have glucosuria, polyuria, polydipsia, they're dehydrated. Their blood is hyperosmolar because of the elevated blood glucose. But because they also have an absolute insulin deficiency, they will accelerate fat breakdown. Okay? They will, in a very accelerated way, break down their stored fat. Any amount of insulin in the body, okay, even with someone who's got a lot of insulin resistance, any amount of insulin in the body really preserves fat stores. Okay. So when you don't have insulin, these fat stores tend to really break down rapidly. And when you metabolize fat, one of the byproducts of that are keto acids. Okay. Keto acids, ketones. Now, with that accelerated fat breakdown, you get this acute buildup of these keto acids. Okay. And that causes an acidosis. Right? So obviously it's a metabolic acidosis. Now the acidosis is going to also cause other complications like CNS depression, nausea, abdominal pain, right, dizziness, just the altered plasma pH are going to cause all these things on top of whatever this person is going through in terms of the hyperglycemia. Okay. Now, ketoacidosis is going to happen more readily when someone is under conditions like trauma, infection, any kind of stress. Okay. The rise in sympathetic activity and corticosteroids that are released during stress responses like this are going to sort of decrease the threshold for the onset of ketoacidosis. So children that have type 1 diabetes that have sort of stable management in terms of the insulin doses and the timing with food, and when they stay home from school because they're sick, right, they often have to check their urine for ketones a lot, because their normal regimen, insulin regimen, may not be enough to prevent the ketoacidosis because of the stress of the infection. Okay. So just a visual on this. So we've got absolute deficiency of insulin, and this ketoacidosis is going to be much, much worse if this patient has excess glucagon, right? Because glucagon is going to accelerate that fat breakdown even more. So all of this is going to be much, much worse with glucagon. So absolute insulin deficiency, you get this breakdown of fat, you get this lack of glucose uptake, okay, which is actually going to cause your lean muscle mass to break down to free up amino acids for gluconeogenesis. Your liver thinks you're starving because it doesn't get that insulin signal, so it breaks down stored glycogen, it goes through gluconeogenesis, and it puts out lots and lots of glucose. So you are hyperglycemic, which is going to cause an osmotic diuresis. You're going to be dehydrated, and your blood pressure might crash because you're so dehydrated. The accelerated fat breakdown causes a buildup of ketones, metabolic acidosis, and that affects brain function. Okay. This is where the person may be hyperventilating, right, the cuspal breathing, to compensate for the acidosis. In a patient like this, they're also going to have, if you remember way back to last semester, the first segment of last semester, when you're acidotic, what happens to your potassium? It goes up. That's right, it gets pushed out of cells. So they're going to be hyperkalemic, right? But there's a sort of paradoxical thing where they appear hyperkalemic, but in reality their total body potassium is actually low because their body's pushed it out of the cells and they're peeing it off. Right? So when you treat these patients with even just insulin, because that's what they need, they can very rapidly become hypokalemic. Right? So there's a lot going on with these patients. And the buildup of the keto acids, they'll actually breathe out the ketones. If you ever come across that description of the sort of sweet, sickeningly sweet breath, and that's the sort of breathing off those ketones. Okay. So why are you not going to see DKA with type 2 diabetes? Because it's not an absolute deficiency. They have enough insulin in their body to prevent this accelerated fat breakdown. Okay. So even though all of this is going on for type 2 diabetics, you're not going to see the metabolic acidosis because they have enough insulin to prevent it from happening. Yeah. If they acquire this absolute insulin deficiency, then they can absolutely develop DKA. Yeah. Yeah. But even small amounts of insulin that they're producing endogenously, right, they really have to get to the point where their beta cells are gone. Okay. So for type 2 diabetics, right, we describe the complications for them as being this HHNK, hyperosmolar hyperglycemic non-ketotic syndrome, right? Which is basically, if I go back to this slide, it's basically the left part of this diagram, right? It's basically this minus the metabolic acidosis with the type 2 diabetics. So that phrase, hyperosmolar, it's hyperosmolar because their glucose levels are very high. Okay. Hyperglycemic, non-ketotic. Okay. Now, the difference really though between DKA and HHNK is in both you can have central nervous system depression and coma. Okay? But in DKA, the coma and central nervous system depression is going to happen at lower plasma glucose levels than with HHNK. Okay? So for someone in DKA, I don't remember what the cutoffs were, but you can end up seeing coma and CNS depression at a blood glucose level much lower than you see coma and depression in HHNK, because the coma and depression is a result of both the hyperosmolar plasma and the acidosis in DKA. But in HHNK, it's just the hyperglycemia and hyperosmolar plasma. Does that make sense? So I'm going to make up numbers. I'm just going to make up numbers. So let's say in someone with type 2 diabetes, you start to see coma at 700 milligrams per deciliter. Okay. In someone with DKA, you can see coma at 400 milligrams per deciliter. Okay. So it's a much lower threshold, glucose threshold, than with HHNK. Okay. And I've run out of time, but I will start with this next time. I'll get into the nitty-gritty of it. But in addition to acute complications, there's also chronic complications to diabetes mellitus, type 1 and type 2. And it's really a result of the toxic nature of hyperglycemia on nervous tissue and vascular tissue. So what you tend to see in a long-term way is injury to large blood vessels and macrovascular disease, including things like coronary artery disease, cerebrovascular disease, peripheral vascular disease. This is all the tendency for hyperglycemia to lead to atherosclerosis. That's what we're talking about with macrovascular disease. Okay? And it causes atherosclerosis throughout the body. So whether it's in the heart or the brain or in the periphery. And then it causes also injury to small blood vessels. So we're talking the microcirculation. Venules, arterioles, meta-arterioles, capillary beds. And hyperglycemia is really thought to thicken, among other things, it thickens the basement membrane, the little bit of connective tissue that separates the small blood vessels from the tissue. Okay. And when you get a thickening of that basement membrane, it really impedes the delivery of oxygen. Okay. And you get poor perfusion to the tissues. And so the microvascular disease associated with diabetes mellitus most commonly affects organs in our body that are highly dependent on capillary density. So we're talking things like the kidneys, right? All those glomerular capillaries, peritubular capillaries, okay? So they all get damaged, and you end up with diabetic nephropathy. Very, very common, unfortunately. And then also diabetic retinopathy. So the retinas is this very delicate layer of nervous tissue where all of our light, the light from the environment, is conveyed by those retinas. And it has a very network of capillaries that it needs to stay healthy. And so diabetic retinopathy is associated with blindness, the onset of blindness in people with diabetes. And then the neuropathies, both autonomic and sensory, are really a result of injury to the nervous system, especially the peripheral nervous system, with hyperglycemia. The autonomic nephropathy, really devastating. So imagine if you pass out every time you go from laying down to sitting up in bed, right? And it means that you can't really walk around much because your orthostatic hypotension is so severe, right? So this is autonomic neuropathy. The damage is to autonomic nerves, and it affects things like regulation of blood pressure and perfusion